tips and tricks for the single implant. So first and foremost, I want to remind everybody that you can follow us on our different social media platforms. I highly encourage you to follow us on Instagram and on Facebook. In our Instagram, we always have a link to all of our webinars so that you can sign up for them. If you visit our webpage as well, www.romerodentalseminars, you can then sign up and just receive free information related to our webinars. We always want to thank our supporters, the companies that make this, make it able to happen for us, and to provide the 1.CE free CE credit to all our followers that want to take advantage of this sponsorship. And we want to thank the companies that sponsor our programs: Colteen, Oral Arts, Dental Laboratories, Garrison Dental Solutions, and Cavo Kerr. And again, you can always visit our webpage, www.romerodentalseminars.com. It is important that you visit our webpage in order for you to be able to get the free CE credit that we're offering today. When you visit our webpage, please make sure that you visit the webinars link. And when you click on the webinars link, there will be a drop-down menu. You will see first that you will find our live webinar series, which is the new topics that are going to be starting, or coming in the near future. We still have, I think, 2 more webinars for this year, and you can sign up in advance to these webinars by visiting our webpage and clicking on the live webinar videos. You will find all the links under that live webinar link. The second link that you have is the on-demand channel. And the on-demand channel is the previous webinars that are recorded and left in our placed in our webpage. They are also in our YouTube channel, and I will show you shortly how to visit our YouTube channel and how to get it, how to take advantage of all the webinars that have been pre-recorded there. You can also submit your quiz for previous webinars. Now, you can only submit the quiz for previous webinars for the same year that we're at. So if you watch our webinars from 2020, you will not be able to get any credit for that, but you will be able to get credit for any 2021 webinar that is in our on-demand channel. And finally, you will find the CE quizzes, which is up there, all uploaded in our webpage. You will find today's CE quiz in our webpage. It's already there. Once we're done with the webinar, make sure that you visit the link, you download the PDF file, you complete the answers. Make sure that you write down all the information that we require that is on the lower part of the form, and we only provide CE credits for US-based dentists. This is our YouTube channel, and again, the simple name, Romero Dental Seminars, and here you will find all of our previous webinars, even from past years. They've all been uploaded here. We keep them in the channel, and there's always easy to access, and they're all free to access. So please make sure that you visit and that you subscribe to our channel so that you can get automatic video emails. Just letting you know that we've uploaded a newer version of any of our webinars. And these are our objectives for today's presentation. Our first objective is to understand the need for atraumatic extraction prior to immediate implant placement. Objective number 2 is how to effectively select the correct surgical hand instruments. Objective number 3, learn when to use implant site dilators. And our objective number 4, understand when immediate implant placement is not an option. So let's go to our tip and trick number 1. And again, these are very clinical presentations. So every idea, every concept, every tip and trick that I'm going to share with you is going to be based out of a clinical case. And I know that you have seen clinical cases like this one that I'm presenting here in your practice. Again, today's presentation is related to the single implant placement, meaning that we're going to place an implant with 2 existing neighboring teeth in place. So this is what we consider a single implant. And again, the idea of this of the single implant for any young dentist out there, this is the way that I would suggest you start your implant journey. If you're not placing implants yet and you want to start to get into this clinical mode, I would highly recommend that you learn your implant placement when in the cases where you're going to have a single implant need. And there's many reasons for that. The number one reason is that the crest of the bone, or the height and width of the bone surrounding this area, is normally ideal for implant placement. There's not a lot of need for bone grafts in situations like this. Sometimes you will find more complex surgical procedures needed, but in many patients, you will find that the height and the width of the bone is adequate for an implant placement. So just learning and making sure that you have these two neighboring teeth, and you can follow the long axis of these teeth and the location, buccal lingual location. It's a big help when you're starting in this area of dentistry. So that's why I'm talking about it, and that's why I'm going to only concentrate on single implants, meaning that they're always going to have some neighboring teeth around them. And my tip and trick number one is, again, traumatic extractions. When you are going to place an implant in a site where there is a pre-existing either tooth or tooth remnant, like you're seeing in this case, you want to make sure that any portions of that tooth are removed with the least trauma possible. You want to try to prevent doing any harm to the buccal or lingual walls, most importantly to the buccal wall, because that will definitely not help you in the immediate implant placement situation. If you have a perforation, if you create a perforation on the buccal wall, or you have a dehiscency on the buccal wall, this is going to require first a graft and then a subsequent surgical procedure for your implant placement. So again, if you have a root there, you know that you're going to have buccal and lingual walls because they're surrounding. That's what what keeps the bone in place is the actual root surface of the tooth. So when you're removing these roots, please make sure that you remove them with care. And I'll show you a couple of instruments and a couple of techniques. In this particular case, believe it or not, this may seem to be, or it may appear to be, a very simple extraction. But when you get in there, these teeth are normally so decayed that the roots just start disintegrating once you start putting any pressure on them. So my advice is always to use very sharp and small type elevator type of instrumentation. Avoid using any burrs unless you have to split the roots. If you have to split the roots because the decay hasn't gotten to the septum yet, then you want to just use a fine cylindrical surgical burr for that separation. And then after that, make sure that you use hand instrumentation. And as you can see, we splitted the roots, and we've been able to remove each of those roots individually without damaging the socket, again, which is what we want to really protect. And you can see here, this is now the tissue surrounding the socket is intact. We have buccal wall, we have lingual wall, and it's very important that you test this, that you prove to yourself that these walls are intact. And the way that you do so is by using a surgical curette. You go into the alveolar process left behind, and you make sure that you curette the buccal and the lingual wall. I always recommend putting your finger on the buccal side of the tissue. Then if there's any penetration or any thin walls, you will feel that instrument touching the wall of the socket. You will feel it in your finger. So you know that if you're feeling something, there's either a very thin wall, there's already a penetration, or a perforation of that buccal wall. So again, if that is the case, we're going to have there's going to be a different treatment modality there. I'll show you a case at the end on how to manage these situations. But for now, for this particular case, we were able to remove these roots without any damage to the alveolar process, to the alveolo here in this particular case. And I want to show you these instruments because normally we carry number 2s and number 3 or 4 size elevators, but we rarely carry these smaller elevators. And for cases like this, I highly recommend the smallest elevator possible. You can combine periotomes and small elevators to just kind of get in between the roots and the root surface and the bone. And again, just think about this: the idea that mechanically one of these objects is the only one that's going to be able to fit in the alveoli. Meaning that if you get a very small elevator within that socket, the root is going to have to come out. It's going to have to displace itself. And that's the reason why you always want to separate the roots. This is the reason why for multi-rooted teeth, you always want to make sure that you split these roots so that you're creating space between the roots. And now that space is the one that you're going to be able to use in your favor when you're trying to elevate these roots. The roots will move toward the space that you have created. And again, I rather create that space in between the roots than on the outer surfaces of the roots. Why? Because on the outer surface I have the buccal and the lingual wall. We already know that the buccal wall is thin, to start with, and by using a burr in that area, all we're going to do is damage that wall even more, thin it out, removes too much of the bone, and maybe creating some exposure for the future threats of the implant. So again, all the ostectomy that you're going to be doing, anything that you do with burrs, you're going to do it within the tooth, splitting the roots, anything within the tooth, without having to damage or without risking yourself damaging the buccal or the lingual walls. And again, this is just to show you that in this particular case, this is the actual x-ray of the patient. You can see that the decay had gone all the way through and had splitted the roots, almost literally splitted the roots for me. So it was very little that I had to use a burr to split the both of the buccal roots. The other thing I want to show you is that in these cases, you normally will have a periapical lesion. And if you do have one, this is not a reason why you should not, what you should think of placing the implant in a second stage. I would literally go in there and just remove, curette this area, make sure that I clean everything nicely within the apical portion of the socket. And then obviously you have to think about this process you want to achieve with your implant. The main goal is that you achieve primary stability. And because you have this large socket, this empty socket now with no root there, and the septum between the roots is very, very thin, the only area you're going to be able to achieve some of that primary stability is going to be apical to the root tips. So you normally have to engage in that bone 2 to 5 millimeters in average. I would say 3 to 5 millimeters in average. The more you engage in that native bone, the more stability you're going to achieve with your implant. And this comes down again to implant design as well. If you have to choose a design, you want to have a design, you may want to choose a design that is a little bit more aggressive, has a little bit more aggressive threads on the apical portion for a situation like this, because again, you want to try to achieve primary stability, and you want to make sure that this implant engages well in those 3 to 5 millimeters apical to the side. But again, the most important thing of this photo here, make sure that you use a curette and that you remove any remnants of any of the lesion that is actually located periapical to the roots before you place this implant. In this particular case, we also had to do a internal sinus lift, and I'll show you the x-ray once we get there. And this is us now preparing the same site for this patient. Once we've extracted the tooth, we've now prepped the socket 3 to 5 millimeters apical, and we knew that we were going to be into the sinus because we had seen the periapical x-ray and the CBCT scan. We knew that we were going to be in that area, so we were prepared ahead of time for to be able to elevate that sinus throughout the alveolar process, what we call an internal sinus lift. That means no lateral window was needed to be done in this particular case. We actually just went ahead and prepped the socket 3 to 5 millimeters apical to the apices of the roots. And once we were at the floor of the sinus, we did a green stick fracture using a mallet. And once we achieved that, we just add some bone to the site, and we're pushing the bone here. As you're seeing with this side dilator, I'm just pushing that bone apically so that when I insert my implant not only engages on that apical bone, but also pushes the graft that I've placed there, and then pushes it towards the sinus so that I can do an internal sinus lift for this particular case. And again, we're just here pushing that graft material within the apical portion, within the floor of the sinus, so that when we place the implant, this is now this is the implant place. When we're driving that implant within the socket, we're doing two things. We're trying to engage the active portion of the apical aspect of the implant within that native bone, and at the same time pushing that graft material again within the socket. This is what this would look like at the end. You can see this is the pre-operative view. You can see the roots were there. We splitted the roots. We removed these roots with a very atraumatic technique, and this is now the implant place. You have seen that the implant is not only in position, but at the same time, we've grafted the site around the implant. Because think about this, if we chose a 4.7 or a 5.0 or even a 5.3 diameter implant, the diameter of the 3 roots is wider than the actual diameter of the implant. So if you think about that aspect, this is a 4.7, but if you think about that, you're going to have some room between that implant that is now very nice, fixed and stable with good primary stability, because you've engaged those 3 to 5 millimeter bone at the apical aspect of the tooth. But you still have these walls that are separated from the implant that you need to add that graft material in order for you to give that implant more a little more support, and make sure that you don't have any tissue growing within the socket. And again, you're seeing here, this is a minimally invasive type of procedure. There is no flap elevation, so we have not disrupted at all the periosteum, which is going to allow second intention healing of this site. And this is beneficial to us because this will prevent any tissue from growing within this graft material that we place around the implant. So these are the things that you want to make sure that you understand through the process. If you've never done a case like this, the whole idea of being minimally invasive or being very conservative in your surgical approach is actually to make this honestly a lot easier. Because if by not disrupting the periosteum, again, you really can allow just second intention healing. What I do for cases like this is I just wait 5 to 10 minutes. I allow the blood to clot around the graft. I don't put any membrane on these patients. I just leave the bone just as seen on this photo. The only thing that I do allow is for the blood to clot, and that's when I send the patient home. I don't move him from my chair until I see that blood clot form and just integrate all that, just surround all that graft that you see on this area. And that's when this patient is ready to be sent home. And you can see here, this is the site of the extraction. You can see where the pearl was located. So now we extracted the root. We clean this area very nicely. We remove any of the of this infective tissue down here. We rinse the socket. We complete our osteotomy. And again, you're seeing here we're maybe 2 millimeters, 2 to 3 millimeters within the socket, but you can see that there's at least 3 millimeters of this implant surrounded by native bone apical to the roots, and the actual cortical plate of the floor of the sinus is engaging on the implant as well. So the primary stability of this implant was ideal the day of implant placement. You can see here where the implant is completely submerged within the bone. And now you can see as well my healing abutment and just the bone that was packed on that socket to make sure that we have an intimate contact between the graft, the implant, and then the graft and the surrounding native bone. So this is what an x-ray should look like after an immediate extraction and immediate implant placement. You don't want to see any space between the implant and the bone. You want to have that area filled completely with your bone graft. So now let's go to our tip and trick number 2. And our tip and trick number 2, again, we're going to continue with being very, very conservative at the time of extraction, being minimally invasive. But I want to show you one more thing. I want to show you, if you want to now extract the implant and you have really good primary stability and you want to immediately load the implant, how do you go about this, and how can you fabricate a really quick temporary for this implant that you're going to be placing? And as you can see here, this is the tooth that we're going to extract, this first premolar. The first premolar had a apical root, external apical root resorption, and this tooth needed to come out. So we were going to extract the tooth, but as you can see, the crown was, the clinical crown was fairly intact. So what I decided to do is I'm going to remove this tooth atraumatically as best as I can, and then I'm going to keep that tooth right next to me, and I'm going to use that tooth, the crown of that tooth, to actually fabricate my temporary, and I'll show you exactly how I do that. But again, you're looking at the extraction side. Once you do the extraction, and in this particular case, we don't use any elevators for cases that have one, like single roots, like premolars or anterior teeth. I like to use periotomes, and I like to use very, very small and sharp periotomes that I can get right in between the actual tooth surface and the bone, so I can impinge directly onto the periodontal ligament. Just cut these fibers that are keeping the tooth in position. Just cut them, all these periodontal fibers out with these thin periotomes all around the tooth. And this is going to make a very, very easy, straightforward, and minimally atraumatic or minimally traumatic extraction. And again, the ultimate goal is that you preserve as much buccal bone as possible. This tooth in particular had intact buccal bone. So this is something that we really, really wanted to protect, because we thought initially when we were studying this case, when we were treatment planning the case, and we were looking at the CBCT, we thought initially, this may be a really good case for us to immediately load, and we're going to give it our best try, because this is a first premolar. Every time our patient smiles, she's going to show that gap in that area. So if we give her a temporary, if we were able to give her, if we were able to immediately load that implant, that was going to help us aesthetically wise immediately after the implant placement. The patient was going to leave with something that looked like her tooth, and that was going to make her obviously more comfortable. These are the periotomes that I would recommend. As you can see, they're very nice, sharp. They come in different angles, either and straight as well. But most importantly, they're very, very small. So they're very easy to get into in between the root surface and the bone, just to go in to cut all those periodontal fibers around the tooth, so that you can gently with a forceps, just very gently move the tooth, buccal, lingual, maybe rotate the tooth a little bit and just extract the tooth. Very straightforward, with very little to no stress built up on the buccal and the lingual wall. Being the buccal wall, again, the thinnest one, the easiest one to damage, and the one that you really, really want to protect. And again, as you can see, no flap. Why am I not doing any flap? I want to keep intact the periosteum. If I keep the periosteum intact, I know that I'm going to have less chances of any buccal bone or any receding of the buccal bone or resorption of the buccal bone. And the reason for that is because the blood supply is maintained constant on that buccal bone. This is why this type of procedures, in my mind, are it's very good that we learn them how to manage them correctly, because again, being minimally invasive just makes our life and our patient's life a lot easier. One of the things that I would highly recommend here is that you extract the tooth. Again, you disrupt all the tissue. The other benefit of this is that the patient has a really quick recuperation, meaning you send the patient home, they barely need any pain medication. There's really no post-operative pain. I always give my patients some antibiotics for cases like this, but other than that, there's really no other pain management that I need to foresee for them, because this, they take this. Again, this is just like a very basic, simple extraction. Literally, this is what it is. And it actually takes me longer to extract the tooth, because I want to protect so much that buccal bone, than to actually place the implant. So once, if you think about it, if we think about this together, the socket is already there. The only thing that we have to do is that we have to understand that we're going to use a very rigid and straight implant. So we're going to have to place the implant a little bit more lingual to the actual position of the root. So once you've extracted the tooth and you're going to start your initial osteotomy, that pilot drill that you're going to use is going to be oriented or directed towards a little bit more towards the lingual. And the best way to describe this, the best way to see this, is just by looking at the occlusal surface of your neighboring tooth. In this particular case, I have this second premolar. I'm going to look at the occlusal surface, and I'm going to look at the central groove. And I want to make sure that my pilot drill is going to be located slightly lingual to that occlusal, to that central groove. That's exactly where I want to start my initial drilling, and I want to always push towards the lingual wall. When you place these implants, you're always going to have a little bit more of a space remaining between the implant and the buccal wall than you would have between the implant and the lingual wall. And again, your ultimate goal, try to engage this implant 3 to 5 millimeters apical to the apices of the alveolar process, or where the roots were located, the apical portion of the roots were located. And the whole idea behind this is that by engaging that bone, you're going to achieve ideal primary stability. This is the ultimate. You need to do this in order for you to be able to immediately load this implant. And we're looking again, the way that I can describe this as a feel is that when you're placing your implant, when you're drilling your implant into the site, you notice that your motor at 30 to 50 Newton square centimeters, the motor literally stops, and you now have to use a wrench and handily deliver the implant within the final position in the socket. So the last 2 to 3 millimeters of you pushing that implant in that site, you literally have to do it by hand because your motor literally stops. It doesn't, you don't want to go beyond 30 to 50 new square centimeters. So now you know that you at least have 30 to 50 new square centimeters. And if you put it, you're driving the rest by hand, you're probably achieving between 50 and 70. And that's more than enough in order for you to be able to immediately load the implant. The other benefit that you have is that, again, you have the added stability given to the site by the buccal and the lingual native bones that the patient has in the socket. So all this put together is what's going to give you that ideal primary stability. And now it's going to allow you to do something like this. You can see my implant has been placed. Before I'm going to place any temporary here, I'm going to first fill that socket with some 70-30 mixture of mineralized and demineralized bone to graft the site. And you can see that I've grafted. You can see the distance between the buccal bone and the actual implant is greater than the distance between the lingual bone and the implant. You can see that this implant, if I draw a line right in the center, is at the central groove, slightly more lingual to the central groove of the neighboring tooth. And these are the geographic, if you want to call them that way. These are the landmarks that I use visually when I'm placing these immediate implants. How do you really need a guide for an immediate implant? Well, it's not going to hurt to have a guide. You can have multiple guides, and we spoke about surgical guides on our previous webinar. So please make sure that you visit our YouTube channel and watch that webinar if you haven't seen it yet. And that gives you a really good description of how we fabricate guides. But the most important thing here is that you have now a socket that's remaining after your extraction, and you have two neighboring teeth that you can, that's why I'm saying this is the ideal situation. This is the way that you want to learn how to do this in your office. You want to have these cases. These are the easiest cases for you to handle because you have all these landmarks that are actually putting you in the ideal position. They're locating the ideal position of your implant ahead of time and for you. So now you see my implants and it's in place. I'm going to go ahead and I'm going to put this healing abutment on top of the implant, or you can use the cover screw as well. And once you put that cover screw, I'm going to now pack in all the bone. You don't want any of this particular bone going into your implant. It's going to be very hard to remove, and then you're not going to be able to screw your abutment, your prosthetic abutment in place. So make sure that you place your cover screw on top. You now condense that bone. I actually use an amalgam condenser that I obviously only use for surgical procedures. And I'm going to condense that bone. I'm going to put some bone in there. I'm going to make sure that I put a lot of pressure to it. I'm going to condense it very nice and tightly. And then I just wait for coagulation of the blood. Once the coagulation happens, I know that this is now, I have fibrin, good enough fibrin around this particular bone, keeping everything in place. Now I'm going to go ahead and remove the cover screw, and I'm going to place the prosthetic abutment, the temporary prosthetic abutment on top of that implant. While I'm doing that, again, remember that I had this tooth that I extracted that I kept right next to me so that I can make an impression. That's what you're seeing here. I'm making an impression of the crown of this tooth, which actually fits in that space perfectly because that's the tooth that she had there before. I'm going to make an impression of that with PVS. I'm going to remove the crown from the impression material, and then I'm just going to fill that up with either bisacryl or PMMA, whichever material you use for temporaries, and then I'm just going to hollow a hole in the intaglio surface of that temporary, just as seen on this photo right here. You can see that I'm now ready to attach this to the temporary abutment. And just make sure that I have the right correct emergence profile, attach it, cement my temporary, and send the patient home with this immediate temporary there. You can see how the tissue is being supported. I mean, very, very straightforward procedure, very fairly easy procedure, very predictable because, again, we're using her natural tooth. It had the ideal contours. Of course, we're going to restore this tooth. We're going to restore this tooth. But this implant is now in place, and we're sending the patient home, not with a space there, not with a gap, not with a huge black space there when she smiles, but rather with a temporary that was made out of her natural tooth and that has been used in this particular case to send her home immediately after the surgical procedure. One little caveat that I do want to give you, as you can see, I've taken the tooth completely out of occlusion. I don't want any lateral excursive contacts for this temporary. This implant is recently placed, and we want to make sure that we keep it undisturbed for at least 8 weeks. So 8 to 12 weeks is the time that I like waiting before I go ahead and pursue a final restoration for this implant. So now let's go to our tip and trick number 3. And our tip and trick number 3 is just going to talk a little bit about how do you manage these same cases. And again, I have two neighboring teeth. I'm going to place one implant here and I'm going to place one implant over here. So these two implants are still considered single implants because they have neighboring natural teeth. So you may have cases like this. Again, I would start with a single with one implant and then just work your way into cases like this that they're still considered single implants, but they're now multiple single implants on the same patient. Now, in this particular case, what I want to share with you is how do you handle cases when the density of the bone is not ideal. In this particular case, we knew by looking at the CBCT and by looking at the periapical x-rays and by knowing the history behind this patient that he had lost his teeth many years ago. We knew that the density of the bone was going to be an issue. We knew that this is something that we may be confronted with. And I want to share with you this quick tip and trick, because the easy thing here to do, or the default thought process here would be, okay, I'm just going to use the actual drills that come in the surgical kit provided by the implant manufacturing company. But again, when you have a bone with less density, and maybe the buccal lingual width is not even the ideal, so you want to try to expand this instead of grafting, instead of doing an onlay graft, you have to use different tools. You cannot use the proprietary drills that come in your surgical kit, because these drills are going to be very aggressive and this bone is going to be very soft. And if the buccal lingual width is not the ideal, you may risk perforating that bone. So what do I recommend doing for cases like this? Well, what I recommend is, in this particular case, we've created this clear surgical guide. And what I recommend here is that you go in with your pilot drill, which is a 2mm pilot drill. You go in with your pilot drill, and right after the pilot drill, you're going to feel it there. When you go in with your pilot drill, you're going to feel that this bone is very soft. That pilot drill is going to go, literally directly to the final depth in a matter of seconds. And you don't really feel any resistance in your hand while you're drilling that pilot drill. So keep this in mind, because implant dentistry is a lot like endodontics. It's a lot like doing root canals. Even though I don't like endodontics and I don't do any root canals, I know the feel of it. And it feels kind of like the same way, when you have a straight canal and there's nothing preventing that file going down, that file is going to go directly to the apex. But when you have these crazy curved canals, you're going to feel some resistance in that canal, and you're going to have to work your way and navigate your way to get to that apical portion a lot more, and it's going to be a lot more difficult than a straightforward case. Well, this is the same thing that happens with these cases, like these implant cases, where you have this bone that is, the buccal lingual width may be a little bit compromised, and you're not 100% sure if the implant is going to be surrounded by the amount of bone that you need. But most importantly, you have a very little density on your bone. So you're going to feel this buttery type of bone where the files are just the drill, that pilot drill just goes in without any resistance from the bone. So when I'm confronted with cases like this, what I like using is the side dilators. And today there's multiple options you can do this. There's actually some drill systems out there that actually can help you obtain the same thing that you can do with these hand instruments. But personally, I still use and I still like the hand dilators. I think that they're a very good tool, and you have a lot of control over them. There is no spinning. There are no rotary instruments being used here. Everything is done by hand. And what I like doing when I'm using these side dilators is, obviously in this particular case, I did a full thickness flap. I'm going to put my finger on the buccal and on the lingual aspect of the bone. And with the side dilators, these side dilators are going to come just like they have their marks. So you have depth marks in them, and they have different widths. And the width is going to be associated with the width of the implant. So instead of using a drill to drill your osteotomy and to place and after that place your implant, you're only going to use your pilot drill. Everything else is going to be dilated with hand instrumentation. So you're going to put these dilators in the socket one by one until you get to the ideal width, to the width that you need based out of the width of the diameter of the implant that you have selected. In this particular case, I think I selected a 3.5 for the first premolar and a 4.0 or 4.3 for the first molar. So I'm going to have to, and again, this tells you that I had limited buccolingual bone width. So obviously, the idea, you can see now the healing of this. And I always tell my residents, just don't be afraid of, elevating your flap and your full thickness flap. Make sure that you can see everything when you're doing these more complex cases, that there is no tooth that needs to be extracted, and you have to work around these not so ideal buccolingual width situations for your implants. This may be the situation where you want to use your dilators, and of course, you want to make sure that you're seeing everything, that you can see everything, and for that, you need to have a full thickness and a well-reflected flap. So here you can see now the implants were placed. I restored the neighboring teeth. And now, the other tip that I want to give you for this particular case, these are Straumann implants. And for these Straumann implants, these are tissue level. I placed 2 tissue level implants for this particular patient. And what I wanted to share with you specifically is this Synocta closed tray implantation, this Synocta system, which is a complete system that comes, you have your impression copies, but you have a specially designed abutment as well. So this is a stock abutment, very nice and well designed stock abutment, very easy system to use. And again, we're trying to simplify things so that we can make it easy for any dentist out there to be able to provide this type of care. If you're using Straumann system, this is a good prosthetic system to use. This is the Synocta closed tray. The Synocta closed tray is actually these 2 plastic components. The first plastic component that you need to place surrounding the implant, and you will hear a click, and you'll click around that tissue level platform of the implant. You're going to use this white sleeve, and that's the first one that you're going to click, and you'll see that this is going to rotate. This should freely rotate left and right, or 360 degrees if you have room for it to rotate 360 degrees around the tissue level platform of the implant. Once you place this white sleeve, then you place your impression coping, which snaps right into the connection aspect of the implant. Is this octagon that you see here is going to snap into place, and all you have to do now is just add some PVS material and pull out your tray, and you have this type of impression. You're going to now connect your analog directly to the octagon that you're seeing right here, and you're ready to send that to the lab for them to fabricate your crowns. You will see here, I have these Synocta abutments have been placed in both of the implants, and now these are the crowns. These are 2 PFM crowns that were developed to go right on top of these abutments. Now, when I'm using a cemented type of restoration, I like using this type of cements, the implant link temporary resin cement, which is very easy to clean, and it will allow you. It's a strong cement, but it's considered weak compared to any type of permanent cement like a glass ionomer or a conventional resin cement, which is going to prevent from you removing the crown eventually if you ever need to remove the crown. So if I'm going to cement my crowns today, I'm not cementing as much as I used to my crowns today. These cases are a little bit older on my stock of cases. But if I were to cement a PFM crown, I would use either temporary cement, or I would use this implant link temporary resin cement, so that the crown can become retrievable if needed in the future. And again, you can see the x-ray now with the final restorations delivered, and you can see the abutments, the implants, everything in place, as well as the occlusal view, the lateral view of the restorations, and the final patient smile from the buccal and from the lateral view. And finally, we're going to get to our tip and trick number 4. And our tip and trick number 4 is, how do I deal with a situation where I don't have a buccal wall? Again, remember that we were talking about this atraumatic extractions. We were talking about protecting that buccal wall because it's so important for us to have bone around our implants. We do not want to place an implant where you're missing buccal bone. That situation can get ugly really, really fast. Now, I have seen, highly skilled periodontists do those type of procedures, and they work very well for them. And if I had a situation where there is missing buccal wall and I, for whatever reason, have a need, or the patient wants to have an immediate implant placed and an immediate graft done, I'm not going to manage that case. I'm going to refer that case to my dear friends, the periodontists, because I know that they're going to be able to do it better than I can. If I am going to handle this case because I'm a general dentist, I'm not a periodontist, I'm not the ultimate surgeon here. I'm a general dentist that has in his armamentarium the ability and the knowledge and the skills to place implants on the cases that I'm sharing with you today. But if I have a case where I'm missing a buccal wall, the way that I manage these cases, that I manage them in a two different surgical times. My first surgical time is going to be extraction of the tooth and repairing of that buccal wall, and then my second surgery is going to be the actual implant placement. So I'm not going to do these cases in one appointment or in one surgical appointment. I'm going to divide this 100% every single time in two separate appointments. You can see here we extracted that tooth. That tooth was completely fractured, and we were missing completely that buccal wall. And I'm just going to share with you this quick video so you can see how much of that wall was missing. I mean, this is what I want. This is the surgical curette that I want you to use. You can see how much of that defect, no buccal wall left there. So think about this. If you place an implant in this socket, you're going to have to, number one, you're going to have to elevate a huge flap. By elevating the flap, you're taking away, the periosteum on the neighboring teeth. You're removing the periosteum from that bone that is covering the buccal wall, the buccal that creates the buccal wall of these neighboring teeth. So I want to make sure that I do not disturb the periosteum. I know that if I keep that periosteum as intact as possible, I know that the outcome is going to be more predictable for me. This is the CBCT of the patient. You can see the huge buccal wall defect that the patient presented because of the fracture. Again, on the lateral view of the CBCT, no buccal wall left. You can see on all the images, no buccal wall left on that tooth number 8. So we knew immediately that we were going to extract the tooth and we were going to repair that buccal wall. How do we repair the buccal wall? What is the number one procedure I recommend? I recommend the ice cream comb technique. And this technique was described in the literature for the first time by Dr. Tarnow. You can review that. You can Google it, and you will find a lot of evidence and literature on this technique. I'm just going to share. I like the technique a lot. I've done it multiple times throughout my career, and every single time it has worked for me the way that I expected it to work. You do have, again, it is technique sensitive, so you got to make sure that you follow the technique and follow their instructions to every in a very pristine and very precise way. So you can see now we've cut this membrane, following the shape of an ice cream cone, and now we push that membrane towards the buccal. This membrane inside the socket should cover from mesial to distal the entire defect, and it should literally rely on native bone. So there was still some bone remaining on the sites of this defect. So we want to make sure that this membrane is supported by that bone. So you got to cut that the cone shape of the ice cream cone is going to be as wide as you need based on the defect. So in this particular case, we knew that we had a large defect. There was a large base on this cone, in that membrane. Now we're gonna, once you do that, once the membrane is in place, without any suturing of the membrane, without anything else other than just keeping that membrane in place as best as you can, we're going to go ahead and we're going to condense 70-30 mineralized, demineralized bone within that socket. This bone has to be packed and condensed very well. You want to make sure you will see that the buccal aspect where you're missing that bone is literally gaining some thickness. You're pushing that tissue slightly more buccal because of the pressure that you're creating within the socket while packing this bone. So you really, really got to pack within the socket. And you can see here we've overpacked the area. Now we're going to fold that membrane towards the lingual, and we're going to suture the membrane to the lingual tissue. And this is how we leave the site. So now you're going to have second intention healing. This is undisturbed periosteum. You're not going to get any infiltration of tissue within your graft, and you're going to have second intention healing. These sutures, I normally like using vicryl sutures. You really don't have to use any type of fancy suturing techniques or anything like that. Just keep things very, very simple. And once these sutures resorb, the tissue is going to grow on top of the membrane, and you're just going to, you can bond a tooth to the neighboring teeth to kind of have something in that area, so the patient doesn't have to leave your office without a tooth. You can use an Essex, you can use a flipper. I mean, there's so many techniques that you can use to kind of provisionalize the area. And then after, we normally wait 4 to 6 months once we do this procedure to get a new CBCT. So now this is our new CBCT. You can see that we have now buccal lingual thickness. We have now a new buccal bone. And I want you to see the buccal bone right here. Is it super cortical? No, it's not. But we have a buccal bone. You can see that we have really good thick alveolar process from buccal to lingual. So, we can definitely place an implant under these circumstances at this point. And you can see here a little bit more of the cortical bone on the right hand side. So we were able to guide the regeneration of the tissue in this area by using this ice cream cone technique. And again, now we're at the time of implant placement. This is now the heal site. This is immediately after the surgery. We allow this to heal. This is now the heal site after 4 to 6 months. We went ahead and we started now our surgical procedure with our pilot drill. And this is now the implant in place. Again, surrounded completely by bone. Look at the gingival margin, the level of the margin, how we were able to keep it there just because of the atraumatic nature of this procedure. Now we're putting our temporary abutment for immediate loading of this implant. We're going to create this nice emergence profile, and we're going to temporize that implant at the day of implant placement. So again, the idea is that you're trying to preserve as much of the tissue contours and the bone. And if you need to replace the bone, there's still some really nice and very minimally invasive techniques that could be used for cases like this.